Good morning, everyone. Good morning. Great to see you all. So many faces. I love the layout. Love the way this is all set up. Welcome to NICON25. And I know many of you have travelled some distance to be here at the conference. So from near and far, thank you for being here today. I'm Donna Traynor, and I will be your host and guide for the next 2 days. It really doesn't seem like 12 months since NICON24, when I stood here to introduce the last conference. Definitely I am a year older. Certainly I am not a year wiser. This conference, it's brilliant. It does actually fill your heart with gladness, if we can say that, because it's so popular, so many delegates, so many exhibitors, and we're really looking forward to a great 2 days. Thankfully, we also have a live streaming from this room, so anyone who cannot attend, because we're jam-packed, but anyone who cannot attend for various reasons will be able to view this room on the live stream. You'll probably know the old adage, if you always do what you've always done, you always get what you've always gotten. Well, over these next 2 days, we are set up to be a collaborative place to share your thoughts, be inspired by others, and make connections that will bring about the reset that is needed in our health and social care system for the benefit of all. Now, I have a little bit of housekeeping, a little bit of practical information for you first. No fire alarm test is planned today, so if the alarm happens, it's the real deal. And the venue staff, the hotel staff, will escort you through the exit doors to the muster point, which is at the bottom of the car park. If you need access to Wi-Fi in the hotel, there are signs up all around the venue. You can see it in the top corner there of our screen. That conference password is for the main room and for the exhibition area. The breakout rooms will be slightly different, but there are signs up around each of those rooms and you can log in accordingly. We have lots of speakers, lots of inspiring discussions here in the main room. Many of you have already attended the breakfast sessions, really well attended this morning. We have more sessions this morning, this afternoon, and later this evening with great opportunities to discuss, to query, and to engage on a really wide range of subjects. And I'll give you just a few for an example. Neighbourhood health, all-island collaboration, mental health priorities, financial sustainability, developing new relationships with business, and making Northern Ireland a prime destination for clinical research. All the information you need, of course, on the sessions and their location is in the delegate guide and the mini guide as well. Information will also be put up on the screen behind me during each period. There are NICON staff members buzzing about the place all day. At reception, you will have had a registration at the table there. Please ask if you need anything at all or you can't find anything. We want you to get the most out of these next 2 days. This is your conference. So please come and go as you please. Go to the session. Feel free to network, make new friends, make old friends, and visit the exhibition spaces. Some really visitors here throughout all the different rooms. We also encourage you to visit the Health and Economy Innovation Zone, which has its own mini agenda with 12 guest entrepreneurs and a range of senior leaders. So please check out that zone as well. As I said, it is your conference. Make the most of it. Now, to formally open the conference, please welcome to the stage the Chair of NICON and Chair of the South Eastern Health and Social Care Trust, Jonathan Patton.
Minister, members of the Northern Ireland Legislative Assembly, Member for the Welsh Legislative Assembly, colleagues, welcome to NICON25. We're delighted to have Mabon Amgwindor join us on a fact-finding visit as he explores healthcare system here in Northern Ireland, along with his NHS colleagues from Wales. Welcome also to the NHS Confederation delegation led by our Chief Executive, Matthew Taylor, CBE. A warm welcome and a welcome back to NICON, to Professor Sir Michael Marmot, CBE, and to Mike Farr, CBE, who makes his appearance this year as Permanent Secretary of the Department of Health. Welcome also to colleagues from the Irish healthcare system who we're now building a much stronger relationship with also. We didn't want to overload you, so we'll deal with peers of the realm tomorrow. I have great pride in telling you that this is our biggest and best NICON conference to date. The quantum and standing of our speakers and contributors, the wide range of topics and issues being discussed over the next 2 days, the range of partners taking commercial space, the waiting list for delegates, the high level of political engagement and support demonstrate that healthcare in Northern Ireland, this is where it's at. This is the place to be. This is the place to hear radical thinking, challenging concepts, inspiring achievements, and you, the delegates, with open minds, expectant, believing anything is possible in the quest to improve the health and well-being of our fellow citizens. But what I've described is only possible because of you, the NICON members. You make it possible. As the sole membership organisation for leaders in health and social care in Northern Ireland, it is your passion for better, your unbounding energy to achieve more, and your desire to deliver high-quality, compassionate care to those in our communities that depend on you, that make health and social care happen in spite of the difficulties that beset us. Thank you for continuing to play your part and supporting us and informing us in what is important to you. We're not in Kansas anymore. The famous words uttered by Judy Garland in the 1939 movie The Wizard of Oz in the role of Dorothy. Whether minister or permanent secretary or non-executive or staff working at any level across the health and social care system, those words will resonate with you. You will recall how Dorothy found herself in an unfamiliar place, uncomfortable, disconcerted, and unsafe. The landscape is far removed from what was anticipated in 2025. We in HSC are navigating the unparalleled pressures, the extreme funding challenges, political constraints, rapidly evolving demands, and increasing patient acuity across all of our services. The healthcare system that we work in right now is unlike anything we have known. It's uncomfortable, it's uncertain, and the future can seem frightening. Yet if you reflect for a moment and recall the last 12 months since we last met here, when our theme was grasping the nettles, we have served tens of thousands of patients, kept children safe, performed thousands of operations and surgeries, listened to and supported some of the most vulnerable in our society. Day after day, in countless homes across our communities, in clinics, in operating theatres, in children's homes, in pharmacies, in GP surgeries, healthcare staff meet their needs. And we have grasped many of those nettles since then. Our economic and political situation in Northern Ireland remains complex and often fragile. Elections are on the horizon, and some observers would indicate that electioneering has already begun. Yet the reform we need has yet to become reality. To use a quote from the recently released report by Pivotal, we are hindered by numerous structural, cultural, and systemic hurdles. If we're to achieve significant change before this mandate ends, we need to increase the pace, take courageous decisions, and make brave steps towards sustainable change. At NICON25, we want to offer you, the membership, the opportunity for learning and to make this better. The Health Innovation and Research Alliance for Northern Ireland describe it in this way. We want to drive collaboration and connectivity across the entire health and life sciences ecosystem. It's about recognizing and harnessing opportunities at every level of the system. This year's theme of conference seeks to amplify and embed the Minister's Reset Plan. You'll all have received this, and it's part of who we are and what we're trying to do at this moment in time. We recognise we have an ambitious but credible plan, well supported with good alignment. HSC leaders have risen to the challenge and have made very significant progress on many existing and new initiatives. Some are already delivering, but many will take some time to mature and deliver material progress for patients. We welcome the increase in involvement from all our partners to support system working and supporting innovation and new ways of working. The pressure remains significant, and we appeal to the executive to find a creative approach to support financial management which will not derail the progress over winter. As I close, I want to recognise and thank our sponsors without whom we could not provide this fabulous opportunity for personal growth and system challenge. To BT, to ABPI, and to AWS, our headline sponsors, a massive thank you. And to our commercial partners on stands as they showcase their contribution to the healthcare system, we're delighted that you're here to support us. So for the next few days, squeeze in as many of the sessions as you can. Open your mind to new ways of thinking and test how you could improve the care and outcomes for our families, friends, and neighbours. So Donna, in the words of my inimitable chairman, crack on.
The Health Minister has called for 2025 to be a watershed year, representing a turning point in how we meet rising demand and drive productivity across the system. He is here to share his ambition and his ask of the system in, as Jonathan talked about, this extremely challenging fiscal environment. We are delighted that he is once again at conference, so please welcome to the stage Minister of Health, Mike Nesbitt.
Thank you, Donna, and good morning, good morning, good morning. I don't think I've ever seen such a large audience in this room, and I've been in it many times. And I think it's just an indicator of how complex, how complicated, and how challenging it is to deliver great health and social care. And you do that day and daily. And to make sure you can continue to do that, it is my job to set a direction of travel, of change, that the next minister come May 2027, hopefully feels compelled to follow. So thank you for the invitation to be here this morning. As you are very, very well aware, we're operating in the context of unprecedented pressures and demands and scarce resources to meet that demand. But within that challenge, there's always an opportunity, and for us it's an opportunity to challenge ourselves. Challenge ourselves, can we think differently? So I want to begin by thanking each of you, not just for being here today, but for your continued commitment to health and social care here in Northern Ireland. I repeat what Donna said, 2025 is a watershed year. We've reached a turning point in how we meet rising demand and drive productivity across the system to try to meet it. We have no choice but to adapt, as Professor Bengoa made clear in this very room last October, and indeed many of you would have been here to hear him. The decisions that we make now will determine whether our system becomes more sustainable, more equitable, and more responsive, or whether it continues to strain under the weight of rising demand, constrained resources, and crisis management. So let me speak frankly. The financial context we face is stark. The 25-26 budget allocation for health provided only a modest increase on last year, but when we account for inflation, rising pay costs, increased national insurance contributions, and growing demand, we're left with an opening shortfall of around £600 million. That is unprecedented and, frankly, conference, unmanageable. and that's why I've gone to the executive and asked for help with pay. The budget understandably prioritised our wholly unacceptable waiting lists. Up to 165 million of that additional 200 million was ring-fenced to address waiting lists urgently. And while reducing those lists is a key objective, a finite budget means channeling funds to this comes at a cost. And the cost is the expense of other service pressures not getting that money. And some of those other pressures are also of critical importance. To manage within our budget allocation, we need to be focused on reducing the deficit in a sustainable way. And I'm clear we must place the HSC on a sound financial footing and have greater stability as we move forward. Simply, we cannot continue doing what we have always done. The system as it stands is financially unsustainable, and without reform, health and social care will consume an ever-growing share of public finances, which is not acceptable to the Northern Ireland Executive. It will crowd out other vital services. It will leave us unable to meet the needs of our population. So we must work in a different way with the resources we have available. So that's why we're resetting not just our budgets, but our entire approach. The Reset Plan, published in July, is our blueprint. It's not a wish list, it's the mandate for action. Financial sustainability is not just a matter for government, it's a shared responsibility. It requires leadership, it requires innovation, it requires collaboration across every part of our system. We must be laser focused on efficiency and on productivity. We must make every pound count. One lost in health is a pound not spent on the economy, on economic inactivity, on education, on educational underachievement. Every pound must count, and we must be willing to make difficult decisions. But because they're necessary, not because they're difficult. Financial sustainability is not just about cutting costs, it's about investing wisely. It's about building a system that's resilient, that's agile, and that's fit for the future, focused on delivering better outcomes for patients, for service users, and for our workforce. The Reset Plan sets out how we'll address the funding gap. It outlines a new model of care, one that's neighbourhood-focused, preventative, and integrated. It prioritises investment in primary and community care, where we can deliver those better outcomes at lower costs. Now, we're not just resetting our systems, we're resetting our culture towards openness, transparency, and respect. This requires a collective effort. It requires urgency, determination, and support from every corner of society. It's really important, and I can't overstate this, that we bring the public along with us as we make those changes. People have to understand why this is happening, and also to be clear about the benefits. They have to start feeling those benefits themselves. Together, we can build a world-class health and social care system, one that meets the needs of today and prepares us for tomorrow. As I mentioned, we have prioritised funding towards the issue affecting many of us, our neighbours and our friends, waiting lists. Progress has been made and work is ongoing to redesign services, to introduce new models of care, and to strengthen the role of primary care. As a consequence, we're seeing a reduction against the longest waits, but waiting lists overall do remain high, with over 700,000 referrals annually. So we need to tackle the current waits, and we are doing so. And I'm pleased to report this morning we are achieving continuing success. Some stats for you. To date, from the beginning of April this year to the end of August, over 100,000 red flag or time-critical patients have been seen, diagnosed or treated, utilising waiting list allocations across the Trust and indeed with the independent sector. There has been a 24% reduction from April to September in the number of people waiting over 4 years for outpatient appointments. That's a patient reduction of 24,811. We've seen a 33% reduction from April to September in the number of people waiting over 4 years for treatment. That's a patient number of 6,683. There has also been significant progress in reducing the number of patients within the named procedure categories since March of 2025. Work in our regional endoscopy centres has resulted in August of this year weights showing a 58% reduction from the peak, which was in June 2022. That's 23,362 patients. And GPs have seen 4,258 patients over 5 pathways: vasectomy, dermatology, gynae, minor injury, and MSK, and that's within the primary care elective service. So overall, that is real progress. But we also need to work to stop the waiting list growing again when the money is spent, because we know when the money goes, if we haven't reformed, the list goes straight back up. So our reforms are not just about clearing backlogs, they're about building a system that will deliver timely, efficient, and person-centred care. At the heart of the reset is the neighbourhood model, the outworking of the shift left I've talked about so often in the past year and a half. It means local where possible, central where necessary. I want to see a future where people are supported to stay well in the first place, keep the healthy healthy, where care is delivered in your home or as close to your front door as possible, where staff are empowered and supported, and where services are efficient and sustainable. My officials have now commenced work to develop a neighbourhood model based on experience from within here in Northern Ireland, learning from Great Britain and indeed beyond. This model will bring together community pharmacy, GPs and their federations, voluntary and community organisations, the HSE trusts, independent providers, statutory bodies, and local government in a formal partnership to deliver integrated care. It will facilitate a preventative approach to healthcare. It will help manage demand much more effectively. It will also enable a reallocation of resources, shifting investment towards primary and community care where it will have the greatest impact. It's a major undertaking, of course, and it will require new ways of thinking. It will require new partnerships. It will require a new approach to service design, but the potential, conference, is enormous. By building care around communities, we can improve outcomes, we can reduce pressure on the acutes, and we can create a more sustainable system. I am in no doubt that in each and every one of you, that you are critical to the delivery of that vision. As I said, I want to see better outcomes for you as well as the people we all serve. So I want to take this opportunity to thank you. Thank you for your commitment and for your efforts, and also for your continued support. Aligning with the neighbourhood model, we must ensure that mental health is valued equally with physical health, not just in policy, but in practice. Mental health is a personal priority for me, as many of you know, and it's a strategic priority in the resetting of the system. Placing a focus on developing the mental health workforce and the Regional Mental Health Crisis Service have been identified as immediate priorities. Both represent crucial enablers for broader system improvement. We're also unlocking the potential of the community and voluntary sector. I want to recognise it as a vital part of our health and social care system. We're developing regionally consistent, person-centred crisis services, reducing reliance on emergency departments and improving integration across all services. Better integration, better recognition and better support for this sector, that's all key to building a more resilient and inclusive workforce. Prioritising timely access, reduced reliance on emergency departments and better integration will help us deliver appropriate support in the right place at the right time. Of course, in the absence of additional funding to support the plan, we will strengthen our efforts to maximise the impact of every existing resource, ensuring it's utilised to its fullest potential for the benefit of our population. We're also addressing the wider social determinants of mental health: poverty, housing, education, employment. We're working closely with the Executive Working Group on mental well-being, resilience and suicide prevention to strengthen partnerships and to deepen collaboration. Alongside these key areas of focus, we must understand how technology is transforming how we work, not just through innovation, but through impact. The rollout of Encompass is well advanced. We now have a unified digital care record across acute, community, mental health, and social care. This is streamlining data sharing, it's reducing duplication, and it's improving the continuity of care. Real-time access to health records is enhancing safety and coordination. Digital innovation is making our system more responsive, more efficient, and more person-centred. So reform is happening. We're taking small steps towards a more agile, more sustainable, and more equitable system. But my battle cry is this: we need more momentum, we need to speed up, we need urgency. Let's be bold, let's be collaborative, and let's be focused. I understand change is not easy, it often requires difficult decisions. However, these decisions have to be considered in the context of what would happen of not taking them, of standing still and being in the same or likely a worse position in 3 or 4 or 5 years' time. So let me close with this thought: reform is not optional. It's essential. We cannot thrive by continuing to do the same thing. We need a system that's fit for the future. It has to be agile, it has to be sustainable, and it has to be person-centred. And the key building blocks are clear: optimism, courage, professional leadership, financial stability. We're resetting not just our systems, but, as I say, our culture. We move towards openness, towards transparency, and above all, respect. It requires a collective effort, urgency, determination, and support from every corner of our society. But together we can build a world-leading health and social care system. And I repeat, we can build a world-class system. And we are blessed to have Mike Farrar as our permanent secretary. And he has a determination, and I have a determination, to move towards delivering a world-class system. With 18 months left in the political mandate, I'm in a rush. The permanent secretary isn't hanging about either. This is a highly consequential year for reform. So listen, I hope each and every one of you stays for a couple of days. I hope you find it stimulating. I hope you find the other speakers are more interesting than I am. Please challenge assumptions, share solutions, commit to the journey, that journey of reform. You all know this, you all know that healthcare is as personal as it gets in life. So I just want to say one thing on a very, very personal basis to each and every one of you. Thank you.
Health equity is at the heart of the reset. Addressing health inequity has been identified as a key ministerial and executive priority. And it's crucial not only to drive better population health outcomes, but also to build a fairer future for all. So how do we ensure that tackling health inequalities is at the heart of this change programme? Well, in this session, we are delighted to hear from the distinguished pioneering expert, Professor Sir Michael Marmot. He is the Director of the Institute of Health Equity at University College London. He advises governments, institutions and communities on embedding equity into health policy and practice. His work for the World Health Organization produced the landmark report, Closing the Gap in a Generation. And he is the man behind the widely known Marmot Review, which addressed health inequalities in England. I'll be putting a few questions to Sir Michael in a few minutes, but first, let's hear his address. Please welcome to the stage Professor Sir Michael Marmot.
and a great pleasure to be here. I prefer the slides here. The opening line of my book, The Health Gap, is why treat people and send them back to the conditions that made them sick. You're all involved in health care, social care, one way or another, vitally important. My concern is with the conditions that make people sick in the first place, not instead of health care, but what we need to prevent people getting sick. You just heard about the Marmot Review, and we did health equity in England, the Marmot Review 10 years on. We had initially 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, employment and working conditions. Number 4, really radical for a rich country. Everybody should be able to eat, have shelter, enough money to live. Number 5, healthy and sustainable places in which to live and work, including housing, and I'll say a bit more about housing in a moment, and taking a social determinants approach to lifestyle, the causes of the causes. We then added to tackle racism, discrimination, and their outcomes. And number 8 was in a way there all along. Pursue environmental sustainability and health equity together. What's been happening to health? It's not a good picture. This is life expectancy for England, Northern Ireland, Wales, and Scotland. And one way of describing health in Northern Ireland, it's like England, only more so. It's stalled. You can take a crumb of comfort if you look at England, Wales, and Scotland. There was a 14-year period where life expectancy did not improve at all. Marginal improvement in Northern Ireland. Just think about that. A 14-year period where life expectancy did not improve at all. The implied promise of society is things will get better all the time. And it's not happening. If you accept the evidence that the conditions that make people sick are the key drivers of what's happening to health, it means society was not improving. That implied promise has been broken. Be a good person, live in society, and things will get better. Wrong. The evidence shows they didn't improve. That's life expectancy. In case you took a crumb of comfort in Northern Ireland saying we didn't look quite as bad as the others, look at healthy life expectancy. Look at the decline in healthy life expectancy. Not only have we broken the promise that things will improve, things are getting worse. This is urgent. This is a winter health crisis that's going on year after year, all year round, in the spring, in the summer. And of course, health is unequally distributed. I mentioned to somebody on the way in, my daughter got married last year. My wife and I went out with a daughter and a new husband for dinner. And I said, here we are, 4 people out for dinner. Mean length of marriage, 26 years. 52 years for my wife and me and 0 years for my daughter. You can imagine what the conversation would be like, people having dinner, being married 26 years, you know, problems with education, aging parents, you know, that's what happens when you've been married for 20. But we'd been married 52, then the distribution is rather important. Averages don't tell you much. So I just told you the average isn't improving. In fact, what we know in England, less so in Northern Ireland, health is getting worse for the poorer people. And the inequalities are getting bigger. In Northern Ireland, over this relatively recent period, the gap hasn't changed much. That was males, this is females. Potential years of life lost. Wow. Enormous gap between the least deprived and the most deprived. And it's been getting worse. What happened in 2010, which is when the rot set in? The government that was elected, and I'm not party political, and it's easy to say that in Northern Ireland. It'd be very complicated if I were. The government that was elected in 2010, the Conservative-led coalition government, had one priority: austerity, rolling back the state. And by golly, they delivered on it. In 2009-10, public sector expenditure was 42% of gross domestic product. Over the decade, that went down year on year. By 2019, 42% had become 35%. When the Labour government was elected last year, they were talking about a black hole of £10 billion, 20 billion. 7% of GDP. I'm not good at sums. Our current GDP is about £2 trillion. Somebody can correct me. 7% of 2 trillion is about 170 billion pounds a year taken out of public sector expenditure. Do you think that could do a bit of damage? I think it could. In my 2010 review, I coined the rather awkward phrase, proportionate universalism. I was trying to get at the idea that in Nordic countries, they have universalist social policies. Applies to everybody. We tend to have targeted policies. You target the worst off. So do you give free school meals to poor kids, or do you give them to everybody? The NHS embodies proportionate universalism. It's a universal service with effort proportionate to need. We don't give everybody the same care. If I died bungee jumping at 97 when the rope snapped, I wouldn't say, damn, I paid my taxes and never got any health care. Be pretty pleased, really. But if I had diabetes and peripheral vascular disease and chronic renal insufficiency and ocular problems, NHS would spend a lot of money on me. Effort proportionate to need. So if we define need socially, we would like a universal system. If we only have a targeted system, so if this is less deprivation and life expectancy, say, we want to level up. If we targeted only the worst off, we might help them. But what about the people who are at disadvantage? Let's say they're in the second bottom quintile, but they missed out by our targeted system. So, universalist policies with effort proportionate to need. What did we get post-2010? My colleagues and I plotted life expectancy for every local authority in England in 2010-12, and then looked at the subsequent reduction in local government spending power up to 2020. What you can see is the shorter the life expectancy in 2010-12, the steeper the subsequent reduction in local government spending power. And most of that, of course, is central government funding. The kindest explanation I can give for this is absent-mindedness. They didn't know what on earth they were doing. But that looks pretty systematic. In what moral universe could it be the right thing to do? The sicker the community, the more money you take away. And then, when someone looking at the data says it's quite possible that your policies led to a stalling of improvement in health, an increase in inequalities in health, and a decline in health in the poorest people. It almost looks like it was deliberate government policy to do that. And this is showing the same thing just by deprivation. In case the government said, no, we weren't targeting sick people, we were just targeting poor communities. The poorer the community, the more money we would take away. That's how you're supposed to work, isn't it? When we look at income poverty, defining child poverty at living in a household at less than 60% median income, the UK had the fastest increase in child poverty of 38 OECD countries. Not inevitable. We were doing things that were making worse for our children in a way that was not going on in other rich countries. Something to be proud of. And in Northern Ireland, if we look at children in poverty before housing costs, if you look after housing costs, poverty levels go up. There's been a recent increase, but it's not a happy story. I mentioned this at the breakfast this morning when I showed in my 2020 report that child poverty had gone up, and it was mentioned in Parliament, and the government said, oh no, we've reduced absolute poverty. They define absolute poverty in a bizarre way. So we looked at data from the Joseph Rowntree Foundation at destitution. Destitution is defined as doing without two or more of housing, heat, light, food, appropriate clothing, and toiletries. In 2022, 1 million children in the UK were in a state of destitution. That's a 2.5-fold increase in 5 years. Children being admitted to hospital with rickets, scurvy, Victorian diseases in the United Kingdom in 2022. Universal credit, the JRF and the Trussell Trust calculated the cost of meeting essentials. Essentials are pretty much like the 6 things that I just listed. And so the horizontal line is the cost of meeting essentials. The histogram is how much you get for universal credit as a single adult or in a family. Universal credit pays about 70% of the cost of meeting essentials. If you're on universal credit, we guarantee you will get sick. We will not give you enough to meet your needs. Cold homes. Why are cold homes bad for health? They damage children's lungs. They damage children's mental health. They have an adverse impact on children's intellectual performance at school. When I was involved with the British Medical Association, the chair of council of the BMA I won't try and reproduce his Edinburgh accent, but he said, "Oh, you can't tell me growing up in a cold home was bad. When I was a lad, we had ice on the inside of the windows." And I said, "Hamish, imagine what you might have achieved if you'd grown up in a warm home." There are three causes of fuel poverty: the quality of housing, the insulation properties of homes in the UK are worse than the European average. We stopped investing in 2012 in home insulation. Save money, it's not needed, this silly insulation stuff. So people live in cold homes. One cause of fuel poverty is poverty, and real incomes did not improve for 18 years in the UK. And then the cost of fuel. I said to an economist, "Can you explain to me why, when the price of gas went up, we paid more for wind power? We paid more for renewables. When the Ukraine war happened, we buy very little gas. So 2/3 of our energy comes from renewables and nuclear. We get very little gas from the Ukraine and Russia. When the war happened and the price of natural gas went up, we paid more for wind." And the economist said, "I'll explain it to you." I still don't get it. I have a sneaking suspicion it's the way we privatized our utilities, because we paid the marginal cost for all our energy, not the average cost. The cost of delivering the last unit gets applied to the whole purchasing. So we've got more expensive energy than the majority in Europe. And we've got a problem of cold homes. Food insecure households in Northern Ireland. If you're in poverty, 25% of children are in food insecure households. Let's get this clear. We're 2022-23. We are in advanced society. And 1/4 of children living in poverty don't know if they'll have meals every day, whether they'll have enough food to satisfy their hunger, or whether they'll have to skip a meal because of lack of money. And if they're not in poverty, it's only, 13% with food insecurity. The most common question I get asked is, "Why aren't you depressed?" This is my answer. We've got more than 50 Marmot places in England, Wales, and Scotland. And I'm looking at you, colleagues. There's one of the countries I didn't mention. Coventry was the first, and I'm a bit embarrassed because this Marmot City business, Coventry didn't ask me. They said, "We're going to be a Marmot City." Okay. When I went to Andy Burnham, the Mayor of Greater Manchester, and I said, "Coventry is doing this, it'd be great if Manchester did it." And then I said to the Chief Executive of Manchester City Council, "I have a request from my wife. Please don't call it Marmot. Call it anything, but not Marmot." "Too late," she said, "too late. We talk about implementing Marmot." One councillor from Manchester said, "You're Marmot." I didn't realise Marmot was a person. We implement Marmot. So Greater Manchester. Then I went to Liverpool, said, "You know what they're doing in Manchester?" So we did a report, Altogether Fairer, and Cheshire and Merseyside, and Lancashire and Cumbria, Luton, Gwent in Wales. And partnerships are absolutely vital. the community and voluntary sector, business, of course, healthcare and other public services. And we're trying to get action locally, nationally, and internationally. I had decided I was not going to the G20 health ministers meeting this year, and an email saying the final report of our Council on Inequality, AIDS and Pandemics will be presented at the G20. Could I go to South Africa to present the report? I haven't said yes yet, but we're on a global agenda. And the community and voluntary sector is vital. We've got a whole program of work with Barnardo's. The British Red Cross has declared itself a Marmot organisation, as has Turning Point. Legal in General approached me. They have, under investment, £1.2 trillion, not small. They said, what can business do? In public health, we've seen business as the enemy, the commercial determinants of health, tobacco, alcohol, fast food, junk food, and the like. We said to business, how about being the good guys, not just the enemy? Most people, a majority, are employed by the private sector, not the public sector. So we said three things: good quality work, pay everybody a real living wage, provide good conditions of work. Goods and services. If you're the tobacco industry, we cannot work with you. If you're the food industry, which side are you on? Are you on the side of profit and making kids fat, or providing healthy, nutritious food at affordable prices? And the wider impact. We know in the NHS, we talk about anchor institutions, the impact on the society, the environment. I haven't said much about healthcare, but healthcare, of course, is important. The East London Foundation Trust declared themselves the first Marmot Trust, taking action on the social determinants of health. They talk about the Marmot Mountains. They took our business report and said, we can do that as a health trust. Our employees, our clients, the quality of service we provide, and the wider impact. And now they've looked through the life course: parent and carer support, mental health support in schools, and so on. Hope. I said to Winnie Byanyima the other day, she's the chief executive of UNAIDS, that a pessimist says things can't get any worse, and an optimist says, oh yes, they can. I used to go around the world saying I was an evidence-based optimist, and a Brazilian colleague said to me, you're using the English language incorrectly. You're not optimistic, you're hopeful. Come back to that in a moment. I'm co-chairing this AIDS, Inequality, AIDS and Pandemic Council with Joe Stiglitz, Nobel Prize-winning economist. He gave me his most recent book to read. My challenge was to read it before he published the next one, which I've managed. And what he's saying is pretty much the same language that I'm speaking. Create a learning society, a rich ecology of institutions, rebalancing power relations. Inequalities and social justice should be at the heart. The role of the state, not communism, not Thatcher Reagan, but the appropriate role of the state, and being suitably modest about the role of economics. When Keir Starmer launched his health mission as leader of the opposition, in a technical appendix on page 12, everybody read page 12, the technical appendix to the health mission. Well, the Royal College of Physicians did. He said the next Labour government will amplify the approach of Marmot cities like Greater Manchester and Coventry by making England a Marmot country. Well, I'm waiting. We've got Scotland. The Welsh Minister of Health announced that Wales will become the first Marmot nation. I'm rather hoping that with the enthusiasm and goodwill of the Minister, which have been amply demonstrated over the last several hours and before, and colleagues here, we might get Northern Ireland to join this party. Why wouldn't you want to do it? To create greater health equity for the population, a fairer society, better education for children, enough money for everybody to live a decent life? Why not? The difference between being optimistic and being hopeful is optimism and pessimism implies certainty. You know what's going to happen. It's going to get better, it's going to get worse. Hope is the opposite of fear. And if we're hopeful, we don't just sit back and wait for things to change. We can work to make it better. I was struck by this quote from Václav Havel. You remember he was a Czech playwright, dissident, and became the first leader of post-communist Czechoslovakia. Hope is not prognostication, so it's not a prediction. It's an orientation of the spirit, an ability to work for something because it is good, not just because it stands a chance to succeed. Colleagues, let's work to achieve greater health equity because it is the right thing to do. Thank you.
Thank you, Sir Michael. If you can take a seat there and take a microphone as well. Just like we have Einstein, and in this part of the world we have Pantridge, now we have met Marmot. So great to be known just by one name. I disagree with your wife on that level. I love your idea and the thought of being hopeful rather than optimistic, because in difficult circumstances, which we've heard from Jonathan and from the minister before you, they painted a bleak picture, but yet a determination to change, to reform, to do things in a different way, to get better outcomes. And health equity is a ministerial priority. But in your experience, and I know you were talking about England, Scotland and Wales, from your experience, how much of it is policy and how much of it is practice, practical implementation?
Oh, they're both absolutely vital. And I'm old-fashioned.
Bring your microphone a little bit closer to your mouth. That would be great. Thank you.
I'm old-fashioned. I believe that evidence really is important. And it's part of a commitment to truth. So the evidence needs to inform policy. And then this crucial step of translating policy into practice. And I've got a very complicated theory of change. I knock on a door, and if it doesn't open, I don't bang my head against it. I find a door that does open. That's my complicated theory of change. So those 50 Marmot places have all opened the door to us and invited us in. if I can get action at a national level, great. But I get action where I can. And so in Italy, for example, the current national government is not terribly sympathetic to this idea, but the Institute of Public Health has created an Italian network of Marmot cities. So the policy is really key. In the Italian case, I'm concerned about how it gets translated into practice. I was in Emilia-Romagna last weekend having exactly this conversation. But in our 50 Marmot places, we start with the practice level. So we've got the policies laid out. Now, how do we put them into practice in all of those places? And it won't be the same in each place because it's got to relate to local conditions and priorities and circumstances.
In our executive, in the Northern Ireland executive, they talk about a joined-up approach. We have talked about it here at conference as well, about collaboration, working together. What other systems do you see need to be part, you mentioned some of them in your presentation, need to be part of that partnership to support the NHS and social care systems, to mobilise action and to make change?
I'm looking at an expert sitting in the front row there. If you look at the 10-year plan for the NHS, it says almost nothing about social determinants of health. It talks about prevention, but prevention's very important. But the way I think about prevention is investing in good early child development, in education, in good working conditions, the kind of things that I talked about. Now that's out with what the Department of Health and Social Care does. It doesn't fit into what most health care organisations do. The reason I quoted from the East London Foundation Trust is they're trying to do that. They're trying to break down the institutional barrier. When I spent a year as president of the British Medical Association, and I met with the GP committee, and I told them about my experience with the fire and rescue service in Liverpool, in the West Midlands. In the West Midlands, they told me about a firefighter. A firefighter told the story of she was called to the flat of an old man because there'd been a fire and he wouldn't let her in. She tried for 2 weeks to get access, and finally she got access, and this old man who'd been living alone, she said, "How come you had a fire?" He said, "I was cold." They turned the electricity off. So this firefighter got the electricity turned back on. She cooked him Christmas dinner. Her dad wondered where his clothes had gone because she clothed this old man. She just got involved. So I went back to the GP. There were lots of examples like this. I went back to the GP committee and said, that's what the firefighters are doing. What are you doing? Are you addressing these things in your patients? So we've got to find a way to break down these institutional barriers. The firefighters can do it, the doctors can do it.
And actually, I'm just looking behind me, one of the shifts of the conference, people to partners. It's that collective responsibility that we all have. I was struck by one of your quotes in your address, if you're on universal credit, we guarantee that you will be sick. When it comes to the business case, how do you get around the financial cost of getting rid of that health inequity?
Well, firstly, let's be honest. Telling the truth, I know, is unusual, but let's do it. So you hear politicians, oh, we're so highly taxed. We're a high-tax country, high-tax country, high-tax country. Until recently, the taxation level in the United Kingdom was 34% of GDP. In the EU 14, it's 40%. We're a low-tax country. The cliche is we want European-style public services with American-style taxation. We're a low-tax country. We decided we're not going to pay for good public services. So we're not going to pay. If you look at unemployment benefits, if you're unemployed in Denmark, you get 100% of what you were getting before. If you're unemployed in the UK, you get 14% of median salary. We're very stingy, and we've decided we're going to lie about our taxation levels and pretend we're a high-tax country. We couldn't afford to be more generous. I mean, my own view is it's far, 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 far better to be in work than not in work. So we don't want the benefit system to encourage people not to work. But if people can't work, let's give them enough money so they can have a proper life.
So finally, you mentioned Denmark there. Is there a country that we should be looking to, or even, I don't want to move to it, but is there a country we should be looking at which has really addressed that inequality, and what we can learn from them?
Well, we did a report for Norway when, can I waste our time by telling you a little story? I was at a WHO meeting, and the Norwegian Minister of Foreign Affairs came to this meeting, and he said, I am a health minister. Every minister is a health minister because what we do in our day job impacts on health. And I thought this was just terrific, so I put it on a slide and showed it everywhere. And then I get a phone call from an official in the Ministry of Health in Norway. She said, you know, you've been quoting our foreign minister as a health minister. He now is our health minister. And he'd like to meet you. So I went to Oslo and I met him. And the official friend said his party will get voted out of office in the next election. He will be made leader and he'll come back as prime minister. And she was quite right. So she then said, you know, he's now the prime minister. Write to him. Write an open letter. I'll get it published in a Norwegian newspaper. So I wrote an open letter to him, reminding him that we'd met, urging him to take action on social determinants of health. The next thing that happened was a bit unexpected. His office got in touch with me and said, would you do a rapid review for us on what we could do? We did. And it was really interesting. You know, I'm used to giving presentations showing how terrible things are. And I was presenting it to the Norwegian Minister of Health in a big audience. And I'm presenting our findings. And Norway looks really good on child poverty, on inequalities. They look really good. They're doing this because they want to be better. They're not relaxed. They still think the level of inequality is too big and it's intolerable. So they look really good and they're really working hard to make it better.
Ladies and gentlemen, please put your hands together for Professor Sir Michael Marmot. Thank you.
So the podcast, Health on the Line, is very popular and widely listened to many of you here and by health and social care leaders. Its host is Matthew Taylor, Chief Executive of the NHS Confederation. Now, we're going to turn this arena now into a live studio because we're going to do a live edition of the podcast. The microphones are ready and so are our guest and host. Matthew's guest is Mike Farrer, Permanent Secretary of the Department of Health. And in this in-depth interview, they will focus on resetting health and social care and why Mike believes the system in Northern Ireland can be world leading. Put your hands together, please, for our podcast host, Matthew Taylor, and his guest, Mike Farrer.
Okay, so there'll be a little intro, which is for the podcast and not for you. But then afterwards, it's all for you. So just so you kind of know what's going to happen. So hello and welcome to this very special edition of Health on the Line, coming to you from the NHS Confederation's NICON25, Northern Ireland's premier annual health and social care conference, bringing together HSA leaders and partners to secure better outcomes for all in Northern Ireland. I'm delighted to be here, and in particular delighted to be sitting down with a special guest, Mike Farrer, a man whose shoes I have, well, metaphorically walked in, as he is a previous CEO of the NHS Confederation. He's incredibly experienced. I think that just means old, yeah, but
I'll take
people
it.
say that about me as well. You know, it's when they use the word veteran. That's when you.
No, it's all relative, Matthew. You're very young, really.
I tell you, the good thing is I do park run, and they do an age-adjusted thing, and every time you move into a different category, my performance improves. So I want to suggest to all of you, do park run, because it's the only thing where things get better as you get older. Mike, I just want to start. Well, first thing is, how do you say your surname? Because there's Farrer.
So I'm from Rochdale, so it's Farrer.
Farrer, yeah.
Northern. It's a good northern.
Down in basic. Not Farrer. I quite like that earlier on over. So, Mike, now we've established your name. Tell us, obviously, you're now here, Permanent Secretary for Health and Social Care, doing really interesting work. But just tell us a little bit about your background. I mentioned the fact that you used to run Confed, but tell us your journey to get to here.
Okay, well, first of all, Matthew, can I just acknowledge, before I start talking about myself, just what a brilliant job I think you're doing and the Confed has done, and NICON in Northern Ireland. It really is impressive, and it was what I was aspiring to do, but you've managed to achieve it. So I just wanted to acknowledge that. My journey, I often start with this, but it is absolutely true, is that I am here as a failure because my chosen career was to try and play professional sport. And I wasn't even good enough to play for Rochdale's first team when we were bottom of the 4th division in 1982. And if that's giving you any
what position did you play, Mike?
Well, you might imagine with a nose like this, I was a centre half. I was a bit of a donkey, and I was too soft, really, because you had to be a bit of a thug to play centre half in those days. And I can assure you that I have none of my own front teeth because they've all been knocked out. But I came into the health service. As a health promotion officer, and I had this kind of view that helping kids on council estates, it speaks to Michael's points completely about getting kids more active in sport would be what being a health promotion officer was. It turned out that I was effectively taking breastfeeding films around for the midwives and health visitors to community clinics, and so it wasn't quite what I imagined it to be. But I then sort of moved from there into drug and alcohol addiction services and mental health services, and was a chief exec in the NHS, very privileged to be so, for around 15 years. And I also had 6 years on secondment to the Department of Health, negotiated the GMS contract from fee-for-service to population. So I had an extraordinary amount of really great opportunities, lucky opportunities, and hopefully I was able to meet those. And then really when Simon Stevens got the NHS chief exec job around 2013, I'd had a bit of aspiration for that, wasn't therefore successful, but thought I'll think about other things, and I went into consulting, and for 13 years was consulting. And one of the great pieces of work that I had was working with the chief execs in Northern Ireland. And that later bridged into doing some work around with the top team in the Department of Health around, interestingly, resetting their culture. When Peter May, my predecessor, said he was standing down, I said, well, I've got lots of ideas about how you might reorganise this, because I've worked for split systems, dual responsibility systems at the top. Gave him a paper and he said, it's fantastic, we really like it, would you do it? And I ended up sort of hoisted by my own petard of ideas, but I have to say what a wonderful privilege it has been to be in Northern Ireland. And I was just thinking when I was listening to Michael, that actually one of the things about my sporting background, and I've continued in sport, haven't actually governed parkrun, but a lot of things like UK Active, Swim England, EFL Football Trust and things like that, is that sport has a great way of when it confronts challenge, it gets inspired by it. So it doesn't get daunted. We tend to be a bit stoical with challenge and sometimes a bit daunted. But sporting people like Jonathan Edwards, when he was the world record holder, you would say to him, Jonathan, we're going to put sand in the sandpit that you're going to jump into. He would say, that's fantastic because I've got to jump over it to avoid being cut. You know, there is nothing, sometimes nauseating, to be frank, how positive people are about sport, about we just lost 8-0, but we're going to take the positives. But the truth is that when you hear about what Michael sets out there by way of a challenge to us in Northern Ireland, what a fantastic privilege it is to have the opportunity to rise to that challenge. And so that's a real inspiration. And if I bring one thing into this role, Matthew, getting into this role, it's that this is the most amazing opportunity we have as a group of leaders to do something incredibly important and special for everybody in Northern Ireland. And so I'm driven by experience and I'm driven by ambition and that aspiration to, you know, work with colleagues in this room to make something great.
Thanks, Mike. In a second, I'm going to ask you, what's the single thing that you've most learned in that career path, or maybe the thing you've changed your view on? But as people might expect, I'm not just going to ask you questions, I'm also going to have all my own opinions. But I just saw something really interesting in your answer in terms of a kind of consistent theme for us at this conference, which is around the relationship between the service and people and patients. And we're publishing a report today that I was handed to refer to, and I've left it on my chair. So Heather's going to bring it up to me in a second so I can wave it around. But just two examples, I thought, really interesting examples. Parkrun, which hundreds of thousands of people run every Saturday morning, all entirely organised by volunteers. It's fantastic. And there are some GPs who prescribe parkrun for people as, you know, part of their kind of couch to 5K. You also mentioned breastfeeding, where the evidence of the health benefits of breastfeeding has gone up, whilst the levels of breastfeeding in the UK have gone down. And in both examples, they're both areas where working with the public as partners, as individuals and as communities is vital to achieving change. But they're also examples of health inequalities, because breastfeeding rates are lowest amongst the most disadvantaged. And whilst I love parkrun, it is achingly middle class. So two really interesting things for us to pick up: partnership with people and health inequalities. But let me return to the question I warned you of, which is, what is the kind of one biggest thing or thing you've changed your mind about in that illustrious career?
So can I pick up first on your points there? Because right at the heart of the reset, and it's the first thing we say, is that we have to change the relationship that we have with citizens about their own health. And that is a massive sort of cultural shift for the service. And most people come into healthcare because they'd like to do good for other people, but that can sometimes get in the way of ourselves feeling that we're empowered. And so right at the heart of the reset, and we should come back to that, Matthew, about what are we trying to do differently to engage people. In terms of a change over my lifetime, I got to be chief exec when I was 39, which was great, in Tees Health Authority in Middlesbrough, which, you know, I've always worked in areas of significant deprivation, which is maybe says something about me in terms of that kind of sense of challenge and what I was trying to do and belief in social justice. But I think I came in as a leader, and so this is a leadership point, feeling that it was my job to have all the answers, to, you know, set that sort of direction, to give confidence. And in part it is, but what I learned increasingly, and I'm 6'4", well, 6'3" now, I've shrunk a bit. I'm 6'3". I used to be 6'2" when I jumped, by the way, which is why I never made it in professional football. It was kind of, you know, somebody else can head the ball. But anyway, what I realised was that when I spoke and made statements, then the more certain I was, the more difficult it was for colleagues around me to contribute to that debate. And I started to realise that the more vulnerable and open to say, what should we do, and ask more questions rather than make more statements, is that I started to realise that I was getting fantastic response. People were wading in to help. People loved the direction but had ideas. And so the one thing that I've learned, which I've tried to convey to people I've talked about leadership, is if you have that ability to be vulnerable and express vulnerability in a constructive way, you will absolutely create a momentum for support and engagement that sometimes when you're a youngish leader, or maybe sometimes an arrogant leader, then you miss all that perspective and diversity and rich contribution. And that would be the thing that I'd learned most about how to lead, really.
Yeah, no, it's really interesting. And I'm going to ask you in a moment about Reset, but my leadership lesson I realised the other day, well, there's two points. And the first is we have to believe in the health service that improving the way we care for patients is also the path to financial sustainability. If we don't believe that, if we believe the path to financial sustainability and the path to better care for our patients take us in opposite directions, we're doomed. And I want to ask you to kind of reflect on that in the context of Reset. But the other thing I've come to believe is this. As a leader, wanting to enjoy your work and wanting your life to be good is aligned with being the best leader you can be. There is a big kind of heroic leadership complex in the NHS, which is if you're not getting up at 6 in the morning and you're not stressed out of your head and you're not in a constant state of personal turmoil, you're not really being a leader. And I want to say that's nonsense, actually. The most effective leaders are enjoying their jobs because they've created around them a team of people who are doing fantastic stuff. They know that they are adding value, not second guessing, and they trust the people who work for them. So that's the thing. Maybe it's just an excuse because I'm old and I want to be lazy, but that's my insight. Let's go to Reset and then think about particularly this question of how do we get recovery, getting back to standards, getting shorter waiting lists, getting the finances under control. How do we reconcile that with transformation? Because so often in the history, these two things have felt like they kind of push against each other.
Yeah, and I think we try to take a pretty broad brush approach to this, and a lot of what we're actually proposing to do is not unknown to the rest of the world, and in many cases has been done better and first in other parts of the world. The key for me was trying to establish right from the word go, why do we need to reset? The why question was the big one around what's going on, and Minister referenced it before about the amount of the public, the block allocation that Northern Ireland has that was going towards healthcare expenditure just being kind of exponential. The last couple of years it's flatlined, but actually it was been heading up inextricably. And really, we were facing a prospect by 2050 that you'd be spending something like 70 to 80% of your budget on health and care. And as I often point out to people, when you look at how we spend that money, most of that is with people at their latter stages of life. So we would have been choosing to spend money in Northern Ireland on the latter stages of people's lives in healthcare delivery, at the expense of starting life for young people, tackling inequalities, environment, education, or job opportunity, transport, leisure, etc. So really getting the why question sorted as to why we had to change. And it's a weird thing because pretty much every permanent secretary, and we've got a few in the audience, gets judged by their own sector on how much money can you get for us. And I'm saying, actually, it's not my job to get more money. What I want to do is see how we can spend the money we've got better, because we should see, and you referenced this, certainly Michael did. In my mindset, health is a horizontal budget. It supports education and attainment by supporting young people's mental health. It creates job opportunities by investment in commercial, clinical trials, life sciences investment. It reduces reoffending rates because we deal with mental health, for people who are in chaotic lives. All those areas, health is a horizontal budget, not just a vertical one. And so what I've been trying to do in Northern Ireland is try and explain that we're not just a drain on people's overall budgets. We're trying to think carefully about how you could use our resources better. And there's a something for something deal in there, by the way, which is if you think about what keeps us well, it's something to do, someone to love, somewhere to live. And none of those are really what we do. We need others to do it. So the something for something deal is with other government departments is that let's see this in a joined up way. But coming back to this idea of reset, we were absolutely saying we're looking at the way we spend money from the wrong end of the telescope, which is, and I think most health systems have suffered from this, is you get forced sometimes politically, Matthew, and you would understand this, to put your resources into the supply side solution to a demand side problem. It's an easier dialogue around we'll build, we'll increase the workforce, etc., than it is to say we'll try and talk to people about how the social conditions of their life impact on their health and what we should do, as Michael was saying, around economic policy and poverty, etc. So what we try to do in the reset is look at this from the other end of the telescope and start with the people and the citizen and say, what could we do to help you, be the best person you can be in terms of your own health? And because I'm a health promotion officer, I'll go into this at some degree of trepidation, but I would argue that our public health messaging has been rather poor because it's focused almost entirely on giving information. And when you give information, you widen inequalities because the people who latch onto that information fastest tend to be the highest socioeconomic groups. What you've got to do is talk to people about not what they just know about health, but what do they feel about health and what do they think others, either normative bit, is normal about health, and get into those areas. So we're trying to use a bit of behavioural science, and I know you've got a lot of expertise around this area and the nudge kind of concepts and moving people. But instead of preaching more at people about what they know about health, is to try and understand what they feel and find ways to help them feel differently and take steps. And we're looking to do a something for something deal where the example I give is, you probably won't be able to see on screen, but I have some hearing aids now. And as a finely honed athlete of previous years, not doing parkrun, you'll imagine it was quite challenging for me to accept that I was going to wear hearing aids. It was something I associated with my granddad. And the point that moved me was when I realized that between 6 and 8% of dementia in older men in particular is due to untreated hearing loss. And I thought, right, that moves me. Now, what would happen, me getting myself some hearing aids is fairly significant in my life, but in the great scheme of things. But what would happen if the HSE wrote to me and said, thank you for doing that, because that's going to really help us. And so one of the things that we're trying to get is, how do we have a different dialogue with the public about how they use services, but how do we sort of try and encourage and thank, very different to public health messages saying there's your 5 a day. So using behavioural science is starting to get people to think differently, more positively about what they can do to make a contribution. And there's a long way to go culturally for the service to accept that. I'll give you one example, and I know I'm talking a bit long here, but I was talking to some young GPs who were saying, and it was rather depressing at one level, because they were saying, if someone walks into my office, again, in my consultation room, and brings a bit of paper in that I've seen this latest treatment, could I have it for the condition I've got, I'm going to kick them straight out. And I thought how opposite that is to the way we should manage somebody or try and work with somebody who's taken an interest in their own condition and is trying to find a way to solve it, to see that as a challenge to us and our authority and our expertise. So we're trying to, this is why people as partners is so different to the way we've tried to do it before. And that's where the reset starts. We can go into the other bits, but that's where we're fundamentally starting this, really.
And this is the document we're launching today with our partners on patient and client council, people to partners, developing a unique approach from Northern Ireland. I think it's available all around the conference venue. Do have a look at it, and I think we've got a session on the report, one of the parallel sessions after this. So Mike, the other thing that has really struck me about your leadership, and it is, I'm afraid, a difficult contrast with England, is that in England, really things do feel very hierarchical. There's a strong kind of culture of kind of control from the centre. You see it in kind of performance management rhetoric, in league tables and all of that. And of course, there has to be accountability, but it's very clear there are some people at the top in charge and there are people in the service trying to deliver. And if you don't deliver, blame is not far behind. You've adopted a much more collegiate approach to how it is you work with the chief executives of the health and care system here. Why have you made that choice, and what do you hope will come from that model of sharing responsibility?
Yeah, I think it starts with the fact I've defined the role that I think I have in a slightly different way, perhaps to the one that's the way in which leaders in England have defined them. I see my job, and indeed the job of my colleagues who work at the centre, if you like, in terms of policy, to create the right context that people out there can lead and deliver services brilliantly, not to tell them how to do their jobs and blame them if they don't. And if we don't get it right at the front line, the first question is, well, what did I do wrong that didn't allow those individuals to do the best job they could do? And what that means is that all the brilliant people, and we have some fantastic people in this room, Matthew, some of the best people I've ever worked with, and I kind of see my job to create the context that they can be absolutely brilliant. So I think it's a definitional point about how do I see my role. And the great news from my perspective, having said that's my mindset, has been the response has been phenomenal in terms of the chief execs, the chairs, as many of the frontline clinicians and the voluntary sector and the people I've tried to talk to have responded really positively for that, because for years, I think, there was a sense in which they weren't enabled to be the best that they could be. And we weren't getting the right decisions. I mentioned in our breakfast session that when you look at the way we take decisions at the moment in Northern Ireland, we've got the wrong decisions in the wrong place. We are too centralised. We're not delegating decisions to the right level, to our trusts, to our trust boards, to our communities. And the only way you can do that is to lead in a way that supports that delegation of authority and responsibility. And with responsibility comes accountability. It's not an easy gig, but the truth is that I believe is the only way in a complex system you get the outcomes. And I think Michael's bit about places and the things that gave him hope, they were things where delegation of responsibility and the policy bit is creating context. And that's, I feel I'm as accountable to our frontliners, and that's the way that I see that job. I'm not always sure that's the way it feels sometimes in England.
So, look, you talked about accountability, so let's talk a little bit about challenge. I've been to NICON 4 times, and I'm standing down at the Confed in March, so I can say that I might never be invited back again when I say what I'm about to say, but nevertheless, when I come to Northern Ireland, what I see is what is really wonderful is the sense of common purpose, the sense of proximity to things, the kind of mutual appreciation, camaraderie. The danger with all of that, with a culture which people so often say, well, everybody knows everybody else, is a certain amount of complacency, a lack of a kind of rigor, a lack of challenge. You don't want to take on your mate that you might see in the pub or whatever it might be. Where do you think this group of people, fantastic people doing amazing work, but where do you want to challenge them, Mike?
Yeah. So I think implicitly we're already in that space, because what I've said is that this country could have one of the best health systems in the world. And when I came, that was a thing where people would say, not everybody in this room, because I think people understand some of that, but people would say, you're kidding me, we've got 4-year waits. Scotland and Wales are 2 years, England's 1 year. What on earth would make you believe that that is possible? And the truth is that we have a lot of fantastic assets that if we brought them together, but ambition and belief, and this goes back to my sporting world, is that you don't start your season thinking we'll end mid-table. We're at the bottom of the league now, we'll end mid-table. You're always pitching for, we are going to be the great. And the challenge has been in Northern Ireland that there's been a little bit of learned helplessness, that our culture's been a bit parent-childish, that we've not liberated and empowered and enabled our front line. And so that culture change is really fundamental, because the pieces of our reset plan, when you read them, you can read in the 10-year vision, you can read in Spain's plan, you can read in, a lot of the countries' plans around what they propose to do. The difference is, do you have a culture and alignment of your kind of ways of working that supports it? And that's the challenge. The challenge in the room is, can we look at ourselves differently? The Minister said it, can we look at ourselves differently in the way that we've always worked? And it's disruption, and it's noisy, and it's uncomfortable. And my challenge in the room is that we're always asking ourselves that question, not when I'm in the room, but when everybody's in the room. Is there a better way of doing it? Why are we doing it this way? And what could we do differently that's better? And who could we learn from? So the challenge is that, but we have to be ambitious. Matthew, you came to the Confed wanting it to be the best it could be. We've got to believe that we can be the best we can be. And there's a bit of belief, but I will never stop asking us to be better. Never stop, because there's always work that we can do to be better. And we've got to quantify that, by the way, and we've got to set ourselves those standards and judge ourselves if we can't, and look at ourselves if we're not delivering. But that's the great challenge in the room.
So that brings me in mind of a point that's got kind of two elements to it, and these are the last two questions I'll be asking you, Mike. So in my experience, the times when I have really deeply learned have involved me feeling a sense of embarrassment, despair. It's been a moment where I thought, my goodness, I've completely got that wrong. The way I've been thinking about that, the way I've been approaching that has been completely wrong. And it's from that I've learned things.
So tell us a bit more, Matthew.
I can give you, I'll give you one example, okay? I'll give you one example, and then, because it's not about me, well, it is. No. When I worked in Downing Street, when I first worked there, I was asked to do something, and we had a meeting, and we were sitting around the table, and Jonathan Powell was there, and various other people were there, and the top team. Tony wasn't there, but the top team. And it came to me, and I was asked whether I'd done the thing that I was supposed to have done. And I started off by going, well, I tried to, but this person let me down. And there was a kind of frisson of horror in the room, because this was a culture where if you were asked to do something, you did it. And if you didn't do it, you found a different way of doing it. What you didn't do was say, well, I tried and someone else let me. It was just completely countercultural. And I went home and I realized I'm no longer allowed to do that kind of thing of saying I tried, but someone else didn't really do what I wanted them to do. And I remember I felt really terrified about that much higher level of accountability than I had previously been. You might just speak to how sloppy I'd been beforehand, I don't know. So the two things I want to say is firstly, neighbourhoods. Now, the Minister spoke eloquently about neighbourhoods. It's a big part of Reset. My view is we will not do neighbourhoods right unless we understand it involves a fundamentally different relationship with patients, a fundamentally different relationship with other public services, and a fundamentally different relationship with communities. And I kind of want to challenge you by saying, do you get how different things would have to be to make this neighbourhood stuff actually work? And then my second question after that will be, as I said, these moments of learning have been moments of pain. And sometimes I think we worry about people's resilience and we feel we can't lead them to those moments of deep learning because it's kind of unfair on them. But I don't think we're doing people favours when we don't. So what's your message about resilience to your colleagues?
So, yes, I honestly do believe that the neighbourhood model, I understand the neighbourhood model, and that's in part because I've worked on small pieces of the neighbourhood model that I think we can bring together in different parts of the country and indeed across the world that exhibit exactly what you described. So the Wigan deal, a something for something deal with a population, an unhealthy population, about how can we keep your council tax down if we fund the voluntary sector and yourselves to try and stay healthier. And they saw things like underspending of social care budget, etc. Swindon troubled families. you know, using the resources, using your data to identify where the drivers were coming from in terms of cost pressures, focusing in on who those families trusted, and your point about a different relationship with the statutory sector just is magnified in that particular example, where families were having visits from 70, 80 people a fortnight coming into their house, different people asking them different questions. These were troubled, complex families. And they asked those families, who do you actually value who comes into your house? And they ended up with 2 or 3 rather than 70. And then they empowered those 2 or 3 to be able to behave holistically. All things changed as a matter of that, because there was a trusting relationship between what the state was offering, whether it's criminal justice, education, health or whatever, and what those families valued. And so those elements we need to build in there. Right at this moment in time, Matthew, we're doing a big consultation exercise, if you like it, with people about what do you believe the neighbourhood should be. But some of those fundamentals are hopefully going to come out of that, baked into the way that we do. So I think we do have a sense of what it is. It's not structural, it's cultural, as well as devolving power and responsibility and decision-making into those communities and joining up some of the public services offer and seeing ourselves as horizontal. So I think we get it, but we'll see whether we can execute it. In terms of resilience, we're asking a huge amount of people now. I don't know, because I can't answer for everybody in this room, whether or not, as we start to look at the reset, people are thinking, my goodness, this is a fundamental question for me about how I've led in the past, what I believe in the past. The people who I see most, and I'll talk about them because most are in the room, and they're a fantastic group of our chief execs. And the one thing I've said to our chief execs is, if we're changing our culture, it starts, if you like, with you. Because being in a parent-child relationship, being the child is quite nice sometimes. You know, you get told what to do, and if you don't do it, okay, you might, but you can, you know, we're asking our chief execs to say, we are going to take responsibility for this whole system along with ourselves and change their mindsets. And we're asking a lot of people, and then that cascades through their organisations. The one thing that I know from my experience today, and I live in Belfast now, and it's one of the most welcoming places in the world. It's just fantastic to live here. And people don't appreciate what you've got, actually, in terms of the warmth and quality, the stunning beauty of the country. I mean, it's just a fantastic place to be. But his people are really determined. When they get a bit between their teeth in Northern Ireland, they're going to do it. And that level of resilience, what I need to be mindful of, and if you'd have asked me my learning journey around my leadership style, is I'm very ambitious, 1,000,000 miles an hour, right? We go for it. And then I look behind and I realise that half the people are out of breath and struggling and not with me. I've got to recognise that we've got to go at the pace that people can manage, but we've got to be ambitious to get that additional sort of like, I'm asking people to do extra, but people should need to call out if it's going too fast and they can't, and we need to support people in that journey. And that matters because we haven't invested for the last 10, 15 years in a lot of succession planning, a lot of leadership development. So there's some really key roles that are coming up in senior positions in all our areas of healthcare where we need to be encouraging people to come forward. If they see the leaders falling over, that's not going to be very helpful in terms of encouraging that next generation. So it really matters alongside the ambition.
And Louise Casey, who worked on that Troubled Families program, one of the things that she also said to me was that when families had started to kind of get their act together and get a better support, one of the first things that they did was they asked that family to help another family. And that was utterly transformative because those people had never been asked to help anybody else, never been trusted to help anybody else, and they took immense pride in being able to help other families go on the journey they've gone. And it reminded me of Richard Titmus's judgment of the Labour government of the post-war era, which is, he said, it's not that we didn't give enough, it's that we didn't ask for enough. So taking the public on this journey with us is absolutely critical. I think, Mike, thank you so much for joining me on Health on the Line.
Absolute pleasure. Thank you, Mike.
So this session is one in which we're going to explore the issue of prevention in a little bit more detail. You've heard a lot about it already this morning through our various speakers. But prevention, one of the key planks of the Reset plan. We probably all know that prevention is something we want to do, we need to do, but there always is that challenge and that tension with investing in prevention and addressing the current need as it's presenting in front of us. So we're just going to talk a little bit about that today. You know, how do we start to reorientate ourselves into the prevention space? What do we need to do differently, and how do we go about doing that differently? The Reset plan's clear that it's an entire system approach that's needed to prevention, and they are fuzzy words, but what that means in reality is, yes, all parts of the health and social care system, but as we heard earlier, the social determinants of health inequalities play large in this and need to be addressed as well. So the entire system approach is reflected in our panel today in terms of who we have. We have people, we're going to talk about the population health pieces with a clinical practitioner, with voluntary community, social enterprise sector, and also industry colleagues here today to talk about the issue. And hopefully, again, what I would like out of today is genuinely for us to pause, think, what does prevention mean in our own world, in our own area of responsibility? What can we do to influence and change the way you do things, the way your team does things, the way your organization does things? And hopefully from hearing the experiences of our panel today, that will start to give you some thoughts. But please, don't let it be a passive thing. Listen today and really have some thoughts about it. The way the session's going to run, we're going to hear from each of our panelists. We have a short video as well, which we'd like you to play just to share some further views beyond the immediate sector. And then we'll have an opportunity to have a discussion. The aim is to have this finished by 1:45. And I've just realised I should have clicked because I can now see myself down there, which I didn't realise, and that's not pleasant. I am Peter Tuga, by the way. I should have said that at the outset, and I'm going to chair the panel today. First person you're going to hear from is Aidan Dawson. Aidan's the Chief Executive of the Public Health Agency. Public Health Agency is a key arm's-length body of the department and one that takes a leading role in driving forward our public health agenda. So Aidan, I invite you to the stage.
Hi, thank you all for coming. I feel a bit of a fraud now being up here because you've had Michael Marmot and now you've got me to talk about inequalities and prevention in a Northern Ireland context. But I suppose what am I going to go through today? And many of you will already know this. What is Northern Ireland famous for? We built the ship that sank. So the Titanic, Blue Lights, which I'm sure you all have either watched or in the middle of watching, no spoilers, the Giant's Causeway, and the other thing that relates to that is the titanic inequalities that we have in our society that give us some very poor ill health for some of our poorest in society. So an overview of what I'm going to speak about over the next 20 minutes, that's just the panic, Peter. Northern Ireland population size and its change, the health of the population and the inequalities, and improving health and reducing health inequalities, tackling the wider determinants of health, and Mike Marmot already spoke about that today, but that's a really important thing, and focus from all of our departments and sectors. So population in Northern Ireland, and you can see it outlined there, and sort of its growth, 1.9 million, and someone said really something last night, I think it was Mike Farah, when he said, Northern Ireland's 1.9 million people. It's small enough to be personal, but big enough to be important. And I think that allows us to do things and make change happen. But if you look at our population and it's changing, the percentage of our population which is now over the age of 65, 17.8 and growing. And we've grown in that age population 13.1% since 1998. And again, we're not a very diverse population. We're quite insular. Our 96.6 of our population is white. 3.4 comes from an ethnic minority background. Now that shifts slightly when you go into the school age, because I think it's around about 6.5% in our school-age population comes from a diverse ethnic minority background. So that again shows you the changing nature of Northern Ireland's population. But when you get into life expectancy, that's when we see some of the real changes. Ill health endured for men in our most deprived area is much greater than it is in our more affluent areas, and similar for women. And that differentiation is one of the things that we really need to tackle. I'm not going to go through all these statistics, but you can see them. And you can actually see them on the screen, but you can see them when you go out. You go into any of our hospitals, you go into any of our streets, you can see that difference between the most affluent areas. And we keep talking about it. We actually need to take some action about it as well, as we all know. But are we doing enough to address it? And again, when we talked about health, and even when the Minister talked this morning, he talked about shift left, about moving from our hospitals, about moving health into our communities and bringing it closer to people. But that's about healthcare. What we actually really need to do is improve the health of our population and have less of them in the healthcare sector being cared for. Because that's what we're really striving for, and that's our real shift left. Make our population healthier and age well, given the changing nature of our population. Which the only part of that is done in healthcare. 40% is your socioeconomic factors, your health behaviours, and then their health services is only 20%, and Minister Nesbitt talked about that, and your physical environment. And again, Mike Marmot talked about housing as being probably one of the most important things in that. So our focus as a public health agency, and it's just one of our focuses, is protecting health. Again, we talked this morning about starting well, about living well, and about aging well, and championing that whole system approach. So this is more about education, it's more about housing, it's more about all those social environmental factors than it is just about healthcare. Actions, and again, Mike Marmot talked about this, universal and targeted. Prevention is one of the key things that we can do for our population, especially our young people. Early detection and intervention in healthcare is one of the things that we really need to do. Things like screening and vaccination. Health improvement programs, getting people to walk more, not even run, just even walk more, get out more into the fresh air. Supporting communities and get them to take responsibility for their health as well, and helping them do that. Having effective services when they're needed, and equitable access. That doesn't mean it's equal for everybody, it means it's equitable. Make it more accessible for those that are more in need. So what causes our premature deaths? And again, it's still the big things that have done it for many, many years. Things haven't really changed in terms of the diet. Ischemic heart disease, suicide is rising and has risen over the last number of years, cancer. All the big things that you'd expect are still up there. Premature mortality, so in 2019-23, preventable mortality in most deprived areas was almost treble that in the least deprived areas. And again, under 75 respiratory disease mortality rate in the most deprived areas was more than treble the rate in the least deprived. Those are the things that we talk about addressing inequalities, and as Mike Marmot said, what causes it? Not just treating the disease, but what causes it and preventing that is a real thing that we need to do. Again, things that we all know, drugs and smoking, mental health and well-being, adults who smoke, 13%, and again, you get into averages. But if we look at it, when we do look at it, we find that 1 in 4 in the most deprived areas smoke, and that moves to 1 in 14 in the more affluent areas. So you can see, and that leads to cancer, it leads to all sorts of respiratory conditions. You can see why that is really important to address the issues around smoking and what drives people to smoke. And smoking kills 2,200 a year, and that's preventable. And then again, when we speak about inclusion health, that is reaching out to our homeless population, those who have been in prison, those that lived in the most deprived areas, and especially our children in inclusion health, our migrants, the children of migrants. Many children of migrants can't actually access GP services in Northern Ireland, which I think reflects really badly in our society. So how do we address things like that? Key things for us. So this was about what is prevention, immunisation and vaccinations. It's a real focus for WHO. Vaccines represent the most cost-effective medical intervention, and that's across the world. That's why they're really important. Global immunisation efforts have saved an estimated 150 million lives. That's when we talk about prevention. However, uptake is declining in Northern Ireland, and we need to address that. That is a real priority for us all. And again, we have lots of collaboration, we have lots of initiatives, we have lots of policies. This is about a call for action. So it's about taking those desires to collaborate and those strategies and turning them into real action, which will make a real difference to the health of our population. Thank you. Thank you.
Thanks, Aidan. So we're going to move on now, and as I said, we're going to hear from all aspects of the system. I don't want to lose, we're going to focus on the different bits of the whole system working today, but let's always bear in mind that what came up this morning around our conversation with the public and how we do that, keep that in your mind as well. But for now, what we're going to have is Chris Hagan. He's the Medical Director in the Belfast Trust, and he's going to give us some clinical insight and thoughts in relation to prevention. Thanks, Chris.
Hi there. It's always great to follow Aidan. I used to work with Aidan. He was told he had 5 minutes, and now he's taken half my time. So anyway, I'm Chris Hagan. I'm the Medical Director of Belfast Trust. I've spent a lot of my time also as a... Could we go back a slide, actually, please? Spent a lot of time as a consultant cancer surgeon as well. What I wanted to talk today was about value-based healthcare or outcome-based healthcare, specifically focusing on what they've done in Scotland around realistic healthcare and how a real focus on shared decision-making and citizen engagement has led to a focus on reducing waste, harm and variation to improve health outcomes for people in Scotland. And there's other examples of this as well. So I thought, as a precursor to how we go about discussing this today, look at some data in Belfast. And this is cross-sectional imaging in Belfast over the past 8 years. We've seen a 70% increase in CT scanning, 20% increase in MRI scanning. And if you look at the red flag data, it's about 200% in MRI and 100% in CT. And it's not been translated to any better outcomes. In fact, we see health in our population deteriorating. Our approach to this is increasing demand, let's buy more scanners, but actually are we taking a step back and saying, is this delivering good outcomes? I said I was a urologist. I had to mention something about urology. Invisible blood in the urine, the prevalence is about 2.5% in the population, in the adult population, and that translates to about 30,000 people roughly with invisible blood in the urine who come for investigation. The pickup rate for malignancy is probably less than 1%. Most people with urological malignancy present with bright red blood in the urine. So just put that as a thought. And then we've seen things in the headlines recently about spending on low-value procedures. I think it's really important also to reflect on the OECD report that looked at spending on low-value care in health. I would argue that we have actually industrialised healthcare globally, not just in Northern Ireland. We've focused primarily on throughput rather than outcomes. We've ignored patients' individuality. We've this real emphasis on outputs and not outcomes, and it puts a lot of pressure on clinical teams to deliver. So I had a really interesting discussion with a cardiologist in a cath lab a few months ago, and they were taking whiteboard patients from around the region, and he had about 20 to 30 minutes to see a patient from another trust, consent them for a really complex procedure and carry out that procedure. There was that wasn't shared decision making. There was no other options discussed. It wasn't a therapeutic relationship. It puts a lot of pressure on clinicians. If there's a mistake or something goes wrong, it's very difficult if you don't have that relationship with that patient or that family. Talked about the OECD report. They also talk about the 60-30-10 rule, and 10% they estimate of care we deliver is actually harmful. So let's look at Northern Ireland, We have delayed ambulance offloads, we have delayed discharges, we have delayed admissions from ED, we have long waiting lists. This is all evidence of harm in the healthcare that we deliver at the moment. I'm not going to talk about this spending because that's been dealt with earlier on today, other than we can't keep doing what we're doing. We have to link into our outcomes, and we have to move to something that is more sustainable, moving away from activity-based to value-based, and prioritise prevention and strengthen the shared decision-making. And realistic medicine, or value-based medicine, provides a route for that. Aidan's already touched on inequalities. So what is realistic health? Catherine Calderwood, who was the CMO in Scotland in about 2015, 2016, led on this in Scotland, and it was picked up really quickly as a project that people could really buy into it, they could really see the benefits on it. And it is about that moving away from more is always better. And in fact, if you take the time to have shared decision-making conversations with patients, oftentimes they will choose less rather than more. So it's essentially a personalised approach to care. And what I also mentioned, I think that was really important in Scotland was the engagement with citizens. And that citizen engagement gave legitimacy to the plans that they put in place. So the core principles are shared decision-making at the centre, reducing harm, reducing waste, reducing variation. Now, variation can be two types of variation. There's warranted and unwarranted. So warranted is where the shared decision-making and you choose a pathway that may not be a standard pathway. But we see a lot of unwarranted variation in Northern Ireland, particularly around inequality, differential access to waiting lists, etc. And again, as I said, citizen engagement is core to this. In Scotland, their citizens panel had about 1,000 people, and there was almost 100% support for shared decision-making. And 90% supported reducing harm and waste. I heard Mike Farrar mention the Wigan deal earlier on today. It's one of my slides. I think it's a really interesting project around citizen engagement, where that Wigan Council had a significant shortfall in budget. They developed a social contract with the council and citizens, and they were able, briefly, to deliver much better care with less resource. Through that engagement. So there are cultural challenges as well as clinical challenges. There's a legacy of paternalistic hierarchical care, and there is great discomfort amongst clinical teams and sometimes patients and families about doing less. And this needs to be supported, I think, with regional policy. I sit in the big discussion group with the CMO where we were talking about what we call sensible care, and hopefully policy will from for that. But we also need to bring on board not only citizens but regulators. One of the great fear for doctors, I'm a doctor, would be how's the regulator or the RQIA or whatever going to view this. Doctors also are quite risk averse, and I think we need to bring them on this journey. They will cite fear of litigation, etc. And I do think that young doctors coming through medical school, there tends to be a sort of cookbook approach to medicine rather than actually personalised. One thing that we don't do in Northern Ireland, if you look at Wales, where they've done something very similar, is they've really embedded patient-recorded outcome measures, and I think we need to do a lot more on that to actually link that back to the value of what we're trying to do. I've talked about shared decision-making. There's the tool called the BRAN, and this was very much part of the What Matters to You campaign. We've talked about reducing harm, waste, and variation. So can we identify as a region what are low-value interventions? Can we say we're not going to do that anymore and we're going to prioritise care to prevention and early intervention? And I think EPIC provides us a big opportunity, but also a big risk. So if you're an EPIC user, you know it's really easy to book tests. You can book lots and lots of tests. I would love to see EPIC putting in best practice guidance as a pop-up, or even hard stops to stop over-investigation. I've referenced how this is embedded in NHS Scotland. All trusts have to have a realistic medicine action plan. My last but one slide is a sort of request, and it's about advanced care planning. And if any of you have time, look at the video on the last 1,000 days by Professor Brian Dolan, really impactful. I didn't know whether to say this, but I'll say it anyway. Whenever I die, I don't want to die in hospital. I want to die at home with my family. I don't want to find myself in the back of an ambulance being transported because there isn't an advanced care plan in place. And I think that if we can do anything around shared decision making, it's making sure that we have advanced care plans in place. And I think everybody that's in this room would agree with that that's not what they would want for themselves or their loved ones. So in conclusion, realistic health means what matters, doing safely, fairly and collaboratively. I think citizen voice is absolutely essential to provide legitimacy for this. Wigan, Scotland, Wales and other areas have shown how it can be done. And at the heart of it is shared decision making with our patients and our clients with an aim to reduce harm, waste and variation.
Thanks, Chris. We'll move swiftly on. We're now going to hear from Gillian Lewis. Gillian's the head of the Northern Ireland Health Collective. The collective works as a forum of forums approach. It provides collaborative voice for voluntary community and social enterprise organisations working in health and social care, community wellbeing services across Northern Ireland. So we could hear your perspective, Gillian. Thanks.
Sorry. I'm delighted to be here. This is my first time at NICON speaking on behalf of the Health Collective, which opened in January, launched in January. So in order to be well behaved, I've scripted myself today and also to keep to my time. So anybody who knows me, that's probably a safe bet. From a community voluntary sector perspective, we see the Reset Plan as an opportunity. We fully support what the Minister and what the Permanent Secretary has said in terms of the ambition around a world-class health service. We see that as absolutely achievable and possible for Northern Ireland. But more importantly, it's essential because we see every day the impact that's having on the people in our communities who are accessing our services and coming to get support within the community and voluntary sector. So in the voluntary community sector, prevention is our everyday practice. It's not a new concept. It's a thread that runs through absolutely everything that we do. But for us, prevention is relational. It's not transactional. And it's about building that trust before crisis happens. It's about supporting the people where they are in real time, reflecting their real lives. And it's about creating spaces within their neighbourhoods and their communities, which is about them being able to feel safe and heard and seen in terms of what's going on for them in their life circumstances. In our work, prevention is about walking alongside people, walking with them in their life experience, supporting their mental health before it breaks down, trying to help families before they reach crisis. It's about connecting people to each other so that there's support within their community and where they live and their neighbourhoods so that they don't fall through the gaps as much as possible. But we see the limits with that approach, and particularly poverty. We've heard that this morning. We've heard it in speakers today. Inequality, health literacy issues, attitudes, behaviours, all impacts on aspects of prevention, from appropriate use of medicines to uptake of vaccines and the wide range of primary and secondary prevention measures that are available. So this disconnect undermines prevention on a day and daily basis within our communities, and that's why it is so important that prevention is embedded both across sectors but also backed by that long-term investment. And it's a hard act to follow, Professor Sir Michael Marmot, but I will focus in on poverty because it does impact on health and it does impact in terms of prevention. Poverty is the biggest barrier to prevention, and almost half of the preventable deaths in Northern Ireland, 47%, were attributable to deprivation in terms of the 2025 Health Inequalities report that was produced. Professor Michael Marmot referred today about 25% of children, 24% of disabled people in Northern Ireland are living in poverty. 20% of families where somebody is disabled are also living in poverty, and of the 42,000 individuals in the learning disability community in Northern Ireland, men will die 23 years earlier and women will die 27 years earlier than the general population, many from diseases and conditions which are preventable or treatable. Currently, nearly 19,500 young children are experiencing homelessness in Northern Ireland. Children in care across the last 5 years spent over 63,000 nights in temporary accommodation, whether that was B&Bs, whether that's rental properties, hotels, even in Wales, Scotland and England, in terms of providing them with temporary accommodation. Our children, young people, families and adults in poverty are facing real barriers, whether that's transport costs, being able to afford to get to hospital appointments for routine checks and follow-ups, whether that's the burden that they carry in terms of care responsibilities, and whether that's digital inclusion, whether that's stigma, whether that's competing survival priorities like being able to afford food. And again, Professor Marmot shared that today. I was lucky in the organisation I was in previously. We were the Northern Ireland case study for the Marmot Review in 2020. And at that point, Professor Michael Marmot highlighted that eating in a healthy diet, as advocated by Public Health England, cost up to 74% of the disposable income for the poorest in our communities. I would imagine that's significantly worse now, given the cost of living crisis. 200,000 people in Northern Ireland faced hunger last year, with 130,000 working age adults, 62,000 children and 12,000 people of pensionable age. That's people every day experiencing hunger in our communities. And this means that children miss things like developmental checks. We have a huge issue in terms of emotional-based school avoidance in Northern Ireland and the SEN provision. So children aren't in school to uptake routine vaccinations and routine checks. Parents are delaying mental health support or other routine appointments. Food is selected for affordability rather than nutritional value. And homes are cold, and we heard this morning about the impact of cold homes, but also some people just don't have homes. And again, Aidan referenced the work that's happening around inclusion health. Screening appointments get missed. Communities disengage with those routine contacts, not because they don't care about their health, not that they don't want the best health that they can get, but they're busy struggling to meet their basic needs, and they're operating within systems that sometimes don't always understand how their lives work. And in communities where there's experience in multiple layers of deprivation, we know that primary care staff, wider health and social care staff, and across all statutory services are overwhelmed with that crisis response and under-resourced for the complexity of need. Hence why initiatives like deep end GP practice programmes are so essential. But prevention can be deprioritised in that crisis-based space. And we see the potential of that. We see that every day in the community and voluntary sector, where increasingly demand for our services are for people with increased complexity of need that we 10 years ago would not be seeing coming through our services. So if we don't tackle poverty, we're not tackling prevention, and all we're doing is damage control. So we need to look at where our levers are and where we can influence change around that. But we can develop a more preventative mindset, and I genuinely believe that the Reset Plan helps to support that. We can act early. We can use all the data that's available to us. The voluntary and community sector are swamped with data and evidence-based reports that usually go to one department and nowhere else and doesn't form that bigger picture. We have community insights around the risks that might be there. We can offer universal support before the crisis hits. We can work collaboratively in order to act early in relation to prevention. Right time, right place, right support, no wrong door. All of those things matter in terms of supporting people in their place. And neighbourhood gives us an opportunity to do that. Partnership with people gives us an opportunity to do that. And that's why the Reset Plan is a real opportunity. Tackling root causes, I think I've covered why that's important in our communities, but it is important to take account of the person sitting in front of you in a clinical setting may have a cold home, may have no money. That might be your responsibility to deal with that, but there's a whole wealth of people within the community and voluntary sector who could be part of that pathway of care, and we're there to connect and be able to do that. We've talked about that partnership with people and about the importance of empowering communities, but we need to invest in that local leadership. Co-design those solutions, really truly co-design those solutions, which reflects that lived experience. And the neighbourhood model does offer us a chance to do that. And finally, shift upstream, that's the easy one. We know that can be achieved. Redesigning policy, shifting funding, that's really straightforward. But those metrics that need to go across our system that actually prioritise prevention. Somebody once said, show me where you spend your money and I'll show me where your priorities are. So, we need to follow through in relation to prevention. And there is ambition within the Reset Plan to do that. So in closing, before Peter drags me off stage, in the voluntary community sector, prevention isn't a concept we just visit occasionally. It is in our daily work, and it's in everything we do, because it's all about the rooted in our relationships and our trust, and the connections we build with people in their families and our communities. And these are individuals who are quite often underserved and overlooked, and quite a lot of the support that we do is about helping them to navigate the system. Something I'm quite often saying is, sometimes people get the services they're given, not the services that they need. And a lot of the work that we do within the voluntary sector is navigating in that space. So to truly reset our approach to prevention, we need to move from intention to action. And that means building those systems that include that lived experience, really value that lived experience, investing in long-term relationships. It is about funding and supporting work on a long-term basis, sharing that power with communities. And it means recognising that prevention is a team effort. Collaboration isn't optional, and in order to sustain our commitment, we need to ensure that that's built in. So in closing, I'll just say, the voluntary community sector are working in this space every day. We are delighted the Reset Plan gives an opportunity for the voluntary community sector to be strategic partners within that integrated space, and we look forward to continuing that journey with you. Thank you.
Thanks, Gillian. Our next panellist is Marion Laverty. Marion's the Head of Public Affairs, Northern Ireland for ABPI. And ABPI, as you know, are one of the event partners for today. So Marion's going to share some views on how pharmaceutical industry can play a role in reset and prevention. Thanks.
Thank you, Peter, and thank you, everyone. So, folks, you will see our logos dotted around numerous places. We've been long-standing supporters of NICON, and we're delighted to be able to continue to do that. So, for those of you who may not know what ABPI stands for, it is the Association of the British Pharmaceutical Industry. So, thankfully, we do shorten that to ABPI because it doesn't exactly roll off the tongue. When we talk about prevention in our world in pharma, I always think 3 is the magic number, so I'm going to talk about 3 things today. So that's vaccinations, medicines, and partnerships. When we talk about vaccinations in pharma, we want everybody to be able to avail of the vaccinations that would be applicable to them. And again, if 3 is the magic number, when we talk about vaccinations, we can talk about 3 things. That's confidence, complacency, and convenience. And you might have heard of the 3 C's model before. But when it comes to confidence in vaccines, we are well aware that pharma is not always seen as a trusted source of information. We acknowledge that, and our work reflects that. So, when it comes to building confidence in vaccines, we have the commitment there to continue to research and develop vaccines for the future, and to continue to support more trusted sources with some of the information that we have on vaccines. We know that, and Aidan's already alluded to it, that there are difficulties in the uptake of vaccinations, and if we can play any part in supporting knowledge sharing or education around the importance of vaccinations, we will continue to do that. When we look at complacency, again, it's almost a trust issue. Vaccines become a sort of victim of their own success. You don't think about things that you've been vaccinated against until they begin to rear their head again. We've seen that most recently with measles. So again, it's back to that commitment of supporting partners where we can when it comes to being complacent about vaccines. And our 3rd C then is convenience, and that's making sure that vaccines can get to people. And we're very good at that, but we probably could be better. I know in Northern Ireland we have huge school immunisation programmes. We also can make vaccines accessible in community pharmacy, for example. But we need to continue to commit to making sure that vaccines that can get to people can get to people. We have the privilege in ABPI to work across all 4 nations, and I'm a big believer in pinching ideas from other parts of the UK and bringing them here to Northern Ireland. And we know there are schemes and things happening in other parts of the UK that we could bring here to Northern Ireland. So, for example, the ConFed are working along with ABPI and with industry to develop a resources hub for vaccines, a source of information, and it's absolutely something we could replicate here in Northern Ireland, and we push to do so. My second point then is medicines, and it's really important that medicines, are given their dues. Medicines keep people well, they keep people working, but medicines are continually seen as a cost rather than being cost effective. And again, it's critical for us here in Northern Ireland to ensure that patients can avail of the most innovative medicines that are available to them. The ABPI carried out research in conjunction with PwC called Transforming Lives, and we looked at 4 disease areas: stroke, kidney disease, and I can't remember the other two, but the point of it was that if those patients, and there were around about 1.2 million patients throughout the UK, if they were switched to the most innovative medicines, it saves thousands upon thousands of bed days, of work days missed. It also saves millions for the economy because those people are well and those people are working. So we need to make sure that patients here in Northern Ireland can avail of the most innovative medicines. Just last week, there was a medicines access review was published by the Department of Health, and there are 10 really proactive, positive recommendations within that report which will ensure that the medicines access pathway here in Northern Ireland becomes much clearer for everyone, for patients, for industry, for prescribers. And the ABPI are right behind those 10 recommendations, and we will strive to bring those to the fore. So my third and final point then is around partnerships. Industry are honestly, they are really keen to work in partnership across health and social care on a number of different issues, but prevention being one of them. Many of our member companies have, pulled projects through in other parts of the UK around screening initiatives, smoking cessation, preventative projects that could easily be mirrored here in Northern Ireland. Within the delegate brochure, you'll actually see our advertisement, and there's a QR code there. And if you have time, scan the QR code and it will bring you straight to our partnership page. And there's guidance there which will demonstrate how industry can work across health and social care on a range of different projects, prevention initiatives being one of them. And here in Northern Ireland, we also have the added benefit of a bespoke framework for industry partnerships called the Health and Social Care Industry Partnership, and it's something that ABPI developed in conjunction with the Medicines Optimisation Innovation Centre, or MOIC, and many of you might be familiar with MOIC. It was launched actually here at NICON quite a few years ago with Minister Swan, so it's a departmentally endorsed framework to allow health and social care to benefit from industry partnerships. And those industry partnerships come very often completely free of charge, but they are a wealth of knowledge, of skills, of resources that health and social care should honestly tap into to meet some of their actions. But that's all from me, folks. Thank you very much indeed.
Thanks, Marion. Very mindful that what you've heard today from our panellists is from the system broadly in health and social care. In preparing for the session today, and what you've heard earlier from earlier contributors, is that prevention goes beyond health and social care and the wider system of health and social care. So in preparation for today, the Public Health Agency spoke to some others outside the system to seek their views on prevention. What does it mean for them and how do we work together? And we just want to share that video with you now, just to hear a wider perspective before we have an opportunity to discuss. So, hopefully.
Here at the Public Health Agency, we believe that prevention is vital to both protecting and improving the health and well-being of everyone in Northern Ireland. But prevention is not simply a matter for individuals with their everyday choices. Prevention goes much wider than that, and it involves how we, as a society, work to tackle the factors that determine poor health outcomes across all of our lifetime. Factors such as the quality of housing that we live in, the education that we receive, the income that we earn, the quality of the environment around us, and the healthcare services that we have access to. If we truly want to see a healthier future for everyone, we need to work differently than before, so that we both challenge and support each other to think prevention first in what we say and what we do. But don't just take my word for it. Let's see what other people think.
Although we are living longer, we are not necessarily living better. As Commissioner, I would like to see a good prevention agenda which will help us add 5 extra healthy, independent years to life, and also narrow the gap in healthy life expectancy between the richest and the poorest across Northern Ireland. A good prevention agenda for ageing will focus on building resilience, maintaining independence, and fostering purpose throughout life. It means moving beyond merely avoiding illness to actively promoting physical activity, strong social connections, and engagement. This holistic approach will help extend our healthy lifespan. It will reduce reliance on our health services and allow people to continue contributing to their communities meaningfully.
I certainly support thousands of people each year in intervention services, but for us it is important not just to support people one-to-one, but to promote prevention, because if people were able to get help earlier and to be able to build up the supports that they need before things got really bad for them, then they wouldn't need those services in the first place. So we need to focus on keeping people well, intervening early, giving them resources that they can use to help themselves and not need to access those services because things fell apart.
The Community Development and Health Network takes a health and all policies approach to prevention in its widest sense. We have been working in partnership with the PHA to support cross-sectoral collaborative approaches to drive long-term change through community-led preventative approaches to tackle the root causes of health inequalities. And through programmes like Elevate, we can work alongside communities, and together we can build healthier and fairer communities for all.
Prevention and early intervention is important within the Connection service in Belfast, as it targets populations and reduces the risk of individuals getting involved in substance use within the communities. It can also reduce the risk of individuals getting involved within organised crime or paramilitary within certain communities in Belfast. It helps people to move on without getting involved with substance use and addiction, and can focus on supporting them to move through trauma without using negative coping mechanisms.
Prevention is the absolute bedrock of public health. Prevention is where we start and we begin to bring health benefits to people as early as possible in their lives, to build their personal resilience, to build communities' resilience. Prevention is the bedrock of health protection.
If we keep reacting to harm instead of preventing it, we're part of the problem. EPOC is a trauma-informed whole systems approach to reducing violence, and it's working. We have learned that this is so much more than turning up to each other's meetings. What works in whole systems approaches is good data, shared outcomes, alignment, trust, joint commissioning, and really rethinking how we understand and respond to need together, not in silos. Whole system approaches are not about everyone being involved in everything. It's everyone understanding the space and place where they add most value and connecting them so that the system acts like a relay team. We know this isn't easy. We can't do it all at once, but it's really worthwhile. Prevention does work. So this week, maybe pick one decision and ask yourself, how do we move this upstream? Who else needs to be in the room for that to happen? That's an easy way for all of us to power up prevention.
So there you have it. We have a short time just to hear some additional views and take hopefully a couple of questions without imposing or impinging on your lunch too much. For me, we all know this is the right thing to do. We've heard today the benefits of doing so and indeed the consequences of not. So this isn't a new discussion. It's not a new concept. One of my responsibilities in the department is to coordinate the prevention aspects of that reset plan. So I'm very interested in action, practical things that we can do to make this happen. Some of the themes, well, 3 themes that came through for me was around, it's about relational, not transactional. I think Gillian mentioned that. Shared decision making, which is what Chris was talking about, and then the use of data in a more meaningful way across all bits of the system. So if I would just pose to the panel to give you time to think, if anyone else wants to ask a question, what is the one practical step we could take now to start moving this forward? We know the benefits, we know what works, but how do we actually bring this into action? Adele sort of stole my mark there, so you can't take her suggestion because that's a really good one. But what's the one thing you would do now to move this forward and bring it into reality? Because we know it all works. Aidan, and we'll just work along if that's okay, quickly.
Thanks, Peter. A number of the
speakers have touched on this, and Michael Marmot touched on as well. Best start in life for our children. We invest a lot in them, but we don't invest enough. And we talked about housing, we talked about many things, but one of the things that we can really do, two things I'm going to say now. Breastfeeding, really important, and how we make that more accessible as a community. And we need to support people to do that and give our children the best start in life. And that is about changing society's behaviours and changing society's attitudes. And it's about working together to take away that stigma, which is unfortunately out there. The other thing I would do is immunisation, because we know it works. I bumped into Carl earlier today. He was a paediatrician that worked in RBHSC with me, and he said he was one of the paediatricians, a consultant paediatrician who'd never seen a case of measles. He'd never seen a case of measles, and he was a consultant. My son's a trainee paediatrician in Liverpool. He saw his first case 18 months ago. He now sees them on a regular basis. I think that reflects really badly on our society. And again, that is about working with our communities. It's about working with people. It's about working with influencers to change that. Measles is entirely preventable. Immunisation prevents it. And we're going backwards rather than forwards as a society. So I think we need to really address those issues and work with our people and our communities in partnership to change attitudes and get our children the best start in life again.
Okay, thanks, Aidan. Chris?
Thanks, Peter. I suppose I would say citizen engagement is going to have to be the thing that's going to unlock this. I think that we can come up with lots of initiatives, but actually how we engage our population in that. And I think it's moving away from doing onto rather than actually involving. And I think that's why Wigan was successful. Heard on the radio this morning about Wakefield having done something similar with a collaboration between council, NHS trusts and voluntary organisations. So I think that because there's a big cultural change to come with this, because we're going to have to explain why we might have to stop doing things of low value to release money to do the things that are actually going to make a difference around prevention. So I fundamentally think that citizen engagement, and if you think that shared decision making is the doctor sitting in front of the patient, I think shared decision making you could expand into our whole population, because it's a shared thing that we're going to do together.
Thanks, Chris. Gillian?
I mean, I could think of across a number of, whether it's breastfeeding, smoking cessation, vaccines, immunisation, screening, issues that we hear from people in our communities about barriers that they experience in terms of accessing those services. But I think fundamentally underlying all of that is an understanding of one of my points in the slide is what's life like for them. And I think the community and voluntary sector, I think, are well placed to support people who are experiencing extremes of disadvantage or inequality, to be able to have that conversation around what life's like for them, and then to understand where their priorities are, what their issues are, and then to think about where prevention fits in that space. So, I would hope that from our engagement today in terms of preventative space, it would be truly delivering on that kind of, there is that contractual arrangement with the community voluntary sector, but moving to that strategic alignment in order to ensure that that lived experience is felt throughout prevention frameworks.
Thanks, Gillian. Marianne?
Thanks, Peter. I think obviously we're coming at this from very different perspectives, and coming from the pharma background. For us, it's just back to that partnership piece. I just think that we see a system that's struggling with finances and resources, etc. And if we can tap into something else that can help with all of that, the collateral benefits will begin to be seen throughout the system, because just as Gillian's alluded to there about those smoking cessation, about immunisation programmes, about screening programmes, I mean, industry can support with all of those things, but I just think we're slow here in Northern Ireland to uptake those offers. And I just think if we were able to get a good constructive relationship built with health and social care, where industry became almost that trusted partner, and seen as that would just be hugely beneficial to everyone.
Thanks, Marion. Yes, I think that concept of we have to do things differently, we have to change mindsets on various levels, and we have to be, I suppose, brave and courageous in doing so. I would just, again, before we have time for one or two questions, but I think Adele's point in the video is really, really important because prevention, yes, there's not this one big thing that'll happen. There will be big initiatives, but it's as much around each and every one of us spotting the one thing that we could do who do we bring into the room that will move the approach in a different manner. And that very much picks up on what our panelists have said as well, but it's a very practical way of us all taking this back to our workplaces. But are there any questions? And please, let's have at least one would be great. Two, and that's probably enough, or else you'll all be starving and the queues for lunch will be very long. But if you could just say who you are and where you're from as well, please.
Anne Henderson from the Public Health Agency. We were talking about decision making and we're talking about engagement with citizens and whatever. Where was the decision ever made that we'd spend so much of our budget and so much of our resources and time on the last 1,000 days of people's health? Was that ever... Is that just the system arrived at that? Why did we arrive in that position as opposed to saying it's going to be the first 1,000 days of your life?
So I was just, Brian Dolan came and gave a talk to us about the last 1,000 days of life, and I think that if you look at how we spend our money, a lot of money is spent on those last days of life, and the most precious thing that people towards the end of life has is time. And it's not being subjected to multiple investigations and tests. The reason I brought it up was around advanced care planning and respect, and I don't think we do that particularly well as a region. And it's about caring for people towards the end of life. But my view is that if we do that right, you will release resource that allows us to focus more on the prevention.
Okay, thank you.
Good afternoon, everyone. I'm Gillian Clifford from RNIB. I just wanted to make a point, really, that I think in terms of prevention, a key component of that is accessible health information and communication. And I think if people can't engage, for example, with some of the public health information that's going out, we obviously support blind and partially sighted people, and they will often struggle with that. So it's ensuring that the communication is accessible. It also bleeds in to things like medicine safety, end-of-life care, your ability to consent to care and treatment. And so what I would say is I would hope that people will engage with organisations such as ourselves, because we're always more than willing and fully supportive of helping to make that information accessible, because prevention messages need to be, whether it's we're looking for awareness raising or ultimately behavioural change, there needs to be that component in order for that to happen. Thank you.
Thank you. Okay, anybody else? Oh, there we go. Yes, good stuff.
Thank you. My name is Pam Nugent. I'm from the Lawrence Trust. I'm the community and voluntary sector. We raise awareness in men of male eating disorders. And eating disorders are at the bottom of the pile. And you talk about prevention. Eating disorders are a major mental health illness. And to prevent it, our ethos and our charity is information, education, prevention. And I was wondering if there's any consideration in Reset about how to support men and women living with eating disorders and the lack of funding there is for research. And you talk about educating children in schools. Children need to be educated in schools about mental health, because as young as 11, 12, 13, they can live with an eating disorder. My son died with an eating disorder at 24. He hadn't the education, nor did we, at the time, know what it was about. That's just what I want to say.
Yeah, thank you for that. And I think there's so much more that we can do. I did have the privilege of running mental health services for a number of years, and I know that we probably don't do enough around our eating disorders, and it was one of the most problematic areas that we faced as a service as well. So look, thank you for raising that as an issue today. I do think we can probably do more. There's always more that we can do as a system. And it's about having those, and we've talked about it today, those engagements which we need to get better at as a system. We are beginning to look at, and we're at early stages, about how we create better conversations with our communities. And I think that has to be more than just our place-based communities. It has to be our communities that have other things in common. And NICE gives us really good guidelines about what communities are. I don't think we do enough about recognising all the different types of communities that are out there. That's another one. And obviously, again, go back to our community of blind people as well. And there is an onus on us in the public sector right across it to create better conversations with our people right across Northern Ireland about how we best serve them, and we need to get better at that. So thank you both for highlighting that.
Gillian, do you want to come in?
Yeah, well, firstly, I'm very sorry about what happened to your son. Also, just to say, from a community voluntary sector perspective, I really value having a chat with you afterwards and thinking about how we can connect up and support some of the work that you're doing. Certainly in relation to kind of weight, and there's a lot of emphasis on kind of obesogenic environments and the obesity strategy. I did a lot of work in Scotland in my previous life, and they talk much more about a healthy weight and about looking at that kind of healthy relationship with food. And I think some of that language is maybe more positive. The other thing is, you're absolutely right in terms of children's mental health and access to support and services, and intervening early before the age of 14 is so important in terms of mental health and access and support. And there has been a huge amount of improvement in that area, but it's very patchy and piecemeal because there's not sustained funding around it. So you're absolutely right to raise it as an issue, and I would really love to have a chat with you afterwards about how we can support you and your organisation.
Okay, I can hear a buzz outside. So listen, I just want to thank you all for coming today. Thanks for showing your interest in that. I would challenge you. What are you going to do differently when you go back? How are you going to change your activity, your behaviour, what you do to embed prevention and a preventative approach into your daily lives? And again, just on behalf of you all, thank the panellists as well for their time and for contributing. Appreciate that, and hope you enjoy the rest of your day. Thank you.